गुड इवनिंग ऑल अटेंडेes एंड पैनलिस्ट टीम। आज का हमारा 22वां फ्री वेबिनार सीरीज है, जिसका टॉपिक है मैनुअल थेरेपी ऑफ सर्वाइकल रीजन, और जिसके रिसोर्स पर्सन है डॉक्टर उमाशंकर मोहंती। तो ये वो शख्सियत आज हमारे साथ है। मेरे लिए उनका परिचय देना तो उनके लिए मेरे शब्द कम पड़ जाएंगे, क्योंकि जो फिजियोथेरेपी प्रोफेशन के लिए जो भी वो काम कर रहे हैं देश लेवल पे और इंटरनेशनल लेवल पे भी, वो बहुत अच्छा मैनुअल थेरेपी में जो काम कर रहे हैं, मेरे शब्द कम पड़ जाएंगे। लेकिन सब्जेक्टिव विवरण के लिए मैं डॉक्टर मेहुल कॉन्ट्रैक्टर को आमंत्रित करता हूँ और सबका परिचय डॉक्टर नेहा वैद्य देंगी। तो प्लीज सर कम एंड गिव योर वर्ड्स टू आवर गेस्ट डॉक्टर उमाशंकर मोहंती।
Yes sir, definitely. Yes, we are back, all of you. Nice to see you all Facebook live and on Zoom live. We are back with the PowerPoint session again. Facebook live, all the viewers and all the participants. Today's speaker Dr. Umasankar Mohanty. Almost all the citizen of nation of India, they knows him very well. Okay, I'm using the whole nation. Okay, I'm using the word whole nation. So the man with the all dignity, knowledge, power, courage, strength, emotions, ethics, I would say ethics, punctuality, the fine crisp, the small thing that keeps in mind and then do the work and give the final result. So the man with, the complete package that I would say in the field of physiotherapy. So, none other than Dr. Umasankar Mohanty sir. Wonderful person. I have personally, spent a lot of time with him, and he shared a lot many things. Apart from, the professional life, he has taught me a lot of lessons of personal life also. So yes, sir, you hold a special, place in my life. And thank you very much for every support that you have given to me. All those Facebook live today, if you see me live through the name of Mehul Contractor, that name was given by Dr. Umasankar Mohanty. Earlier it was Mehul Madi, right? Those who know me well, earlier it was Mehul Madi, but he was the one who gave me the name, and he created every single thing, supportive technically on the Facebook, and he created my name over there. So I would say I am the one of the luckiest person that he created my Facebook profile, right? So full support that I have got till date, and जितना भी बोलूँ ना उनके बारे में बहुत कम है, बट एक चीज जो मैं आपको ज्यादा मतलब उनके बारे में बताना चाहूंगा वो ये है that if you want to work ethical, okay, if you want to work with lot of punctuality, then one must go under training with Mohanty sir. That is what I can tell you. I can write and tell you, not simply telling. I can write and tell you, if you want to work ethically as a clinician, if you are a clinician, and if you want to work ethically with your patient, and if you clearly, if the mindset should be very much clear that what are you up to and what you are going to do. Okay, so that ethics, that punctuality and everything, if you want to really learn in your life, then the best man that you got is with us today on screen, Dr. Umasankar Mohanty sir. If you want to very much work ethically as a clinician, and if you very much sir, that you have accepted our invitation, and then we are together still. We are socially we are separated, but still virtually we are together. So once again, thank you sir. Now over to you, Neha ma'am. Please warmly welcome this sir, and then we'll start the session. Thank you sir.
Thank you for your kind words. Yes,
thank you so much sir. A very good evening to one and all present over here on this virtual platform. I, Dr. Neha Vaidya, Assistant Professor at Odhavram Physiotherapy College, on behalf of E.N. Patel Medical Campus, would like to thank you all for being with us. And also I want to extend my gratitude to our principal sir to give me this opportunity to welcome a very well-known personality in physiotherapy community, Dr. Umasankar Mohanty, sir. Second time that sir is sparing his valuable time for us and providing us opportunity to learn from him. Sir is founder and president of Manual Therapy Foundation of India. Sir has done his bachelor's from Swami Vivekananda National Institute of Rehabilitation and Training and Research, Cuttack, and master's from Manipal College of Allied Health Sciences, Manipal. Sir has done his PhD from Mangrol University. Sir has trained more than 24,000 physiotherapists in manual therapy across the globe. Sir has presented several research papers in manual therapy at national and international level. Sir has done more than 35 publications in international journals and magazines. Mohanty sir is author of two books, that is Manual Therapy of Pelvic Complex and Clinical Symposia in Manual Therapy. Sir has also conducted many hands-on workshops in manual therapy across the globe. Sir has developed a new technique for the soft tissue palpation, which is called as Mohanty flat palpation grade. Sir was also elected as the President of Indian Association of Physiotherapy. Sir is member of International Society of Education in Physiotherapy, and Sir is visiting faculty to educate physiotherapy events Dubai, Integrated Manual Physical Therapy, Manila, Philippines, a Sri Lankan Society of Physiotherapy, Sri Lanka, Bangladesh Federation of Orthopedic Manipulative Therapy, Dhaka, F.A.G.E, Faridabad, Lovely Professional University, Punjab, M.I.A.P Physiotherapy College, Noida, S.C.D College of Physiotherapy, Ahmedabad, S.P.B College of Physiotherapy, Surat. Now, without wasting much of your time, I would like to invite Sir to commence the webinar. Sir, over to you. Thank you so much.
So, thank you, first of all, Prakash sir, and Dr. Mehul, Dr. Neha, and thank you. Although I have interacted with Dr. Neha, but I have spent a great deal of time with Prakash Bhai and with Dr. Mehul. And I remember the great memories are very fresh,
Yes.
conducting one workshop in your college. And thank you, Dr. Mehul and Prakash sir, for sharing each and every single word. And it was very, respectful for me. And I really am delighted. And once the lockdown is over, I think again I will catch up.
Sure, sir.
Sure, sir.
We'll
Sure,
catch
sir.
up.
We will meet.
Yes.
Definitely.
Right. Yes. And good evening to all the participants who are attending this webinar. And I'll be making the session primarily a practical based, and so that when we are doing something in practical and we just see the skills, then definitely that is more better and appropriate. I feel that when I attend any session, I'm interested as a physio to see the skills. And when Dr. Mehul contractor told me that, I just told him, you select the time and he selected this time, and I agreed with him. And today we are dealing with the cervical spine. And in the present situation, you all are attending, just to give one very simple example, all are attending this webinar, and you are attending either, I think a majority of people will be using the mobile phone or using the computer. So obviously, or the laptop. I think computer desktop also has become slowly, a remote way of doing things. And you see that almost in the entire humankind today, if we see everybody is using a mobile phone, or in every office, people are using computer or laptops. So obviously that leads to more problem in the cervical spine. Previously, as far as the musculoskeletal conditions are concerned, let us see the entire chunk of problem in the humanity. If you see the low back pain is the second most commonest healthcare problem. I'm not talking about musculoskeletal problems, just talking about the extent of involvement. The second most commonest problem is the low back pain, and the first commonest problem, why I'm giving the emphasis is that the first most commonest healthcare problem is the common cold. And you see the entire world is suffering today due to a chronic form of the common cold, and that is the corona or COVID-19. And I wish that with the cases increasing, we have to be cautious, careful as physiotherapists or as individuals. So I'll suggest you that to take all the possible measures to keep yourself safe and your patient safe. So we are talking about the cervical problem. And as I said that I'll be showing the first, I'll be discussing the from a skeletal model. Okay, so you see, when we talk about the cervical problems, we will be dividing it as, let me talk about a little bit of the anatomical aspect of the cervical region. We divide in anatomy, classical anatomy, the cervical region into three: upper cervical spine, mid cervical spine, and lower cervical spine. Upper cervical spine is from CO to C3, which includes the CO-C1 joint, the convex concave joint here, the CO-C1, the convex occipital condyle moves with the concave C1, and C1, C2 is a biconvex joint, then C2 and down, the facet joint. These are the facet joints. So, as I told you that commonly in the usage of the computers and the usage of the mobile phone, so it leads to, you know, the trigger points. And cervicogenic headaches, which is very common problem I come across as a clinical physiotherapist, the cervicogenic headaches. The headaches felt due to the involvement of the cervical region are called as cervicogenic headaches. Later, I'll be putting you, once we finish towards the end of the session, I'll be just going through the cervicogenic headache. And further, I'll be telling you how to differentiate when I'm doing further practical demonstrations on the subject. But upper cervical spine, we are dividing as upper, middle, and lower. So C1 to C3, C3 to C5, and C5 to C7. Upper, middle, and lower. But in manual therapy, we are taking as upper and the lower one. We are merging the mid cervical and the lower cervical together. So that's what about the anatomical part. And then something just what is one common problem we will come across? Just stand like that. Yes, one of the common problem what we will come across is this upper cross syndrome. I just showed you that, and another important thing is that for proper functioning of any region, we require three things: the passive component, active component, and the neural component. The passive component, I just showed you that what are the basic skeletal configuration division of the cervical spine, the upper and the lower cervical spine. That is the passive component. What is the active component? What gives dynamicity to the structures? That is the active component. You see the active component here, obviously the suboccipital muscle is here, the traps is there, the levator scapula is there, the sternocleidomastoid is there, the ventral deep neck flexors are there. One common muscular imbalance is very common. One imbalance, muscular imbalance, that is called as upper cross syndrome. What is upper cross syndrome? In upper cross syndrome, we have these structures, this cross of muscles, especially the suboccipitals, the levator scapula, the pectoralis major, pectoralis minor. This cross becomes tight and this cross becomes weak. The deep neck flexors and the scapular retractors, they are weak. So this particular muscular imbalance, and obviously you just see that suppose somebody is holding the mobile phone, obviously the neck is translating forward. So a poor body posture, and a lot of work is going on in present times on ergonomics. And it has come in the guidelines also, because I give consultancy to so many companies, ergonomic consultancies, and the specific requirements are there by the inspectors that they have to appoint the physiotherapist or somebody who has got knowledge of ergonomics to take care of their employees. And any office you go, people are sitting, head is translated forward in front of the PC, and over a period of time, if the head is translating, just translate your head forward. Yes, you just observe. It leads to a bifocal posture. This is called as a bifocal posture. The bifocal posture, obviously you can see here, this particular structures become, this particular area, the suboccipitals, that goes for the tightness. And now what you can do, one small experiment. While you are listening to me, you take your these 4 fingers and put it at this area, and put it at this area below the occiput, and then poke the chin out. Just poke the chin out. You can feel the contraction of your suboccipital muscles, the suboccipital muscles. So what happens if there is a constant anterior translation of the head? The suboccipitals are going to develop tightness, and over a period of time, it is going to develop a trigger point, the suboccipital muscles. And the suboccipital muscles are attaching to the dura mater. And obviously, when suboccipital muscles become tight, that pulls the dura mater. And when the dura is getting pulled, dura gets pulled, that can cause the exertional headaches. Why? Because the major drainage processes, major venous system inside the cranial cavity, we have the superior sagittal sinus, we have the inferior sagittal sinus, and then we have the transverse sinus. Major venous systems. And when the dura becomes tight, that will occlude or restrict the venous system. And due to the venous congestion, the person may develop the headaches. And that is called as cervicogenic headache. What is cervicogenic headache? Headaches perceived due to the involvement of the cervical region. That can be due to the passive component, due to the skeletal component problem, that could be due to the muscular component problem, or that could be due to the neural issues like the tightness of the dura impeding or restricting the venous transport system. So this is one basic introduction I just gave you, and I'll just put some, as we are in the era of evidence-based practice, I'll be putting some facts in front of you, some slides. So the cervical pain are common, as I told you, are rivaled only by low back pain. Among the musculoskeletal problems, low back pain is more common. Commonly we'll see in our clinics. And next comes the cervical problem. And next, osteoarthritis is also quite common. So international figure indicate that at any point in time, approximately 10 to 15% of the population will be suffering an episode of neck pain, and 40% will suffer neck pain during 12 months period. Neck pain is a musculoskeletal disorder, as I said you, that it could be due to the involvement of the joints and involvement of the muscles or involvement of the neural components. The poor body posture, I just explained that you see, this is the poor body posture. This is the head is translated forward. This is a bifocal posture. As well as poor design of the workstation. These two things are very important. Sometimes patient comes, we treat, and we send the person back. After 5 days, 10 days, or 15 days, person again comes back and tells that same pain has again recurred back. That means when we are treating, we have to ask also the person to take some photographs of the workstation. Always, it is very important for all the clinical therapists, you must do it. You ask that when you are working, because the person is spending about 6 to 8 hours in front of in the office. You tell that whatever is the regular posture or the work he does or she does, that various angles, the photos should be taken, and then you see the workstation. And if any changes has to be done, you need to change that. Okay, so poor design of the workstation may lead to muscle pain, particularly the shoulders. Along with the neck issue, we will have involvement of the shoulder region also. So neck, lower arms and wrist, which if not attended to may develop into what are commonly called as repetitive strain injuries, RSIs. So alarmingly, 30 to 50% of the general population suffer from neck pain annually, with a prevalence of around 15% in males and 23% in females. In females, the incidence of neck pain are more. And these numbers are increasing with time. And this is the bifocal posture. And as I said, with the cervicogenic headache, it is a unilateral headache. I'll tell you towards the end of the session, I'll tell you there's a difference between migraine and cervicogenic headache. And just one point, if you remember, the cervicogenic headache is often unilateral. And migraine can be at any part of the brain or any part of the cranial cavity. It can arise. Localized to the neck, occipital region, projecting to the frontal and temporal region. Mostly it is unilateral. And Justard was the first person to explain about it. And there is a difference between further differentiation. I'll just tell you between cervicogenic headaches and between the migraine. And often the cause of cervicogenic headache is the trigger points. So muscular trigger point are usually found in the suboccipital area. I told you to do the palpation of the suboccipital muscles in cervical region, shoulder musculature, and these trigger points can also refer pain to the head when manually or physically stimulated. And to identify the trigger point, this is the pincer palpation. This is the pincer grasp. Yes. So you can see that this is the, I'm taking a little bit more close. This is the pincer palpation. And when we are palpating, we have to palpate perpendicular to the orientation of the muscle. And if there is a trigger point, there will be intense pain. And that is called a jump sign. And this already I explained to you about upper cross syndrome, where we have got the tightness of the trapezius, levator scapula, and tightness of the pectorals, weakness of the deep neck flexors, and weakness of the rhomboids. So this already I just explained. And this was explained by Vladimir Yanda initially, and further more important points I'll just discuss. And for the proper functioning of any region, I said that it is essential that we should have proper passive component, articular component, that is, we should have proper muscular component and proper neural component. So now with the basic, just down, here, right. So I'll just show you the various movements, examination, manual therapy examination for the upper cervical spine, for the lower cervical spine, and I'll also show you that how to identify the trigger point. And let me just tell you about the basic sequencing of manual therapy examination. First, obviously, we have to do the observation. In observation, you just see if there is any, just stand up, yes. In observation, you have to just see if there is any, sometimes we can see there is important, any prominent line will be there. Normally there is no line. You can see posture observation, there can be line. If there is line above that and below that, there will be a tendency for hypermobility or stiffness. That is one thing. In lateral observation, we have to see that if the head is translated more forward, and we have to see the cervical lordosis, if it is accentuated or if it is increased. And we have to specifically observe this area, that if it is just translated forward, okay. If this is a bifocal posture, if the person is having excessive translation, we have to observe for this area also. Because obviously what happens when there is translation, more stress will be coming at one particular point or one particular joint. And then at the same time, just in the anterior view, we have to look for the sternocleidomastoid primarily. And if there is a trigger point in sternocleidomastoid, that can produce the frontal headache. A person comes and tells that I am having the frontal headache over here there is headache, then there is a possibility of a trigger point in sternocleidomastoid. Just to isolate, you just palpate the, this is the pincer palpation. I was just showing in the video a priori. You just, this is the pincer palpation. You just think about the crab or a scorpion, and you just see their grasp, that you just think about the scorpion, that front part, it has the mechanism, you know, to hold, that is the pincer mechanism. So you have to, for the palpation of the trigger point, what is one trigger point? A trigger point is one electrically active, hyper irritable foci found inside the muscle fascicles, and it is exhibited primarily by the skeletal muscles. And there are so many C fibers taking origin from that focus. Therefore, when we palpate, due to intense pain, a person jumps. Now, jump is not like you see in some Tamil movies or you see in some dubbed Hindi movies. You know, it is a small, due to the pain, sometimes the person can do like this. That is the jump sign. So due to intense pain. So what I was telling is, if there is a trigger point in the sternocleidomastoid muscle, that can produce the frontal pain in the frontal region. And this is specifically the terion. The terion is the junction of the frontal, parietal, temporal, and greater wing of sphenoid. So what happens is that if the trigger point is there in sternocleidomastoid, it is going to pull the epicranial fascia. The stress somehow comes here, and the person experiences of the frontal headache. So it is a classical presentation of cervicogenic headache. It's a left side sternocleidomastoid. This is you palpate, it is painful, there is some swelling, and there is pain in the frontal region. And in case of suboccipital muscles, we will have occipital headache. In case of trapezius, you know, the trapezius is attached to the superior knuckle line, the medial aspect. So sometimes in case of trapezius spasm and trigger point, at this area, superior knuckle line, when you palpate, you will find swelling. Enthesis will be there. Why that swelling will be there? Due to the pull of the muscle. And that can produce the occipital headache. So the trigger points of the traps, upper traps, will cause occipital headache, suboccipital will cause occipital headache. And as I said, that suboccipital, one component of the suboccipital muscle, the suboccipital muscle has got so many subcomponents, like obliquus capitis superior, obliquus capitis inferior, rectus capitis posterior minor, and rectus capitis posterior major. These are the 4 components of the suboccipitals. A lot of research work is going on about the cervicogenic headaches and the suboccipital muscles. And out of this, the most smallest muscle is the rectus capitis posterior minor, and that muscle is having attachment to the dura. And so in grossly, you can tell that the suboccipital is tight. That is going to cause the headaches, especially occipital headache. And it can cause, because of the pull of the dura, it can cause irritation in other parts also. But primarily, it will cause occipital headaches. Okay, just sit down. Now we'll do the examination for the just from this angle, right? Okay, fine. So for the upper cervical spine, I'll do the examination, active movements with overpressure for the upper cervical spine. So while you are listening to the talk, if you can practice, it is fine. Otherwise, you can do at least simulating the movement on yourself to understand what exactly, you know, where the pressure and all is coming from. So we are doing the upper cervical, how to isolate. Is it one articular problem, periarticular problem, neural problem? After observation, I already said that we have to do the posterior observation, lateral observation, and anterior observation. Next step, what we are going to do is active movements with overpressures. So for the upper cervical flexion, ask the person to do the chin tuck. So you yourself, while you are listening to the talk, you just place your 4 fingers at the below the occiput and then just tuck the chin in. With chin tuck, you can feel the movement. There is upper cervical spine flexion. Just do the chin tuck. Therapist is placing one hand on the occiput, and the first waist space is kept anterior to the mental tuberosity, here, and apply the overpressure. You have to go to the barrier, 1, 2, 3, 4. And maybe many students might be attending for the first time. Just to explain you about the barrier, you can just see that I am giving the example for the wrist. The same understanding, because what is barrier, I have to just tell you. For doing the wrist flexion, so you are doing the wrist flexion, and better you can just do it just to experience or just to feel what I am exactly trying to communicate to you. Take it for flexion. This is the active movement, and this active physiological movement is possible because of the joint play. First, there has to be joint play, then active movement. Then you go for passive movement. It's the passive movement. After the passive movement, you can feel there is the resistance. That is the physiological barrier. And then you move further, then it is the anatomical barrier. The space between the physiological barrier and the anatomical barrier is called as the paraphysiological space. So when I'm talking about the barrier, I'm talking about the physiological barrier, I'm talking about the paraphysiological space. Because the mobilization has to be primarily applied, whether for soft tissues or for the joint. So this concept of barrier concept understanding is extremely important, right? So flexion, tuck the chin in, and then overpressure. Go to the barrier, 1, 2, 3, 4. We are applying the force from the occiput, anterior superior force. And from the anterior placement, the force is applied posterior superior. You go to the barrier, as I just explained to you, physiological barrier, and give overpressure. 1, 2, 3, 4. If the pain will be felt, now you just imagine, if there is suboccipital tightness is there, this is upper cervical spine flexion. The joints are supposed to open up. If there is suboccipital tightness, that is going to produce the pain. And if the localized pain is produced, normally there is no pain. If the pain is produced, that means there is possibility of the tightness of the suboccipital muscles or the tightness of the capsule. then we have to correlate with the end fills. If it is capsular, the end fill is leathery. If it is muscular, the end fill is elastic. Take it in, overpressure. 1, 2, 3, 4. Upper cervical spine flexion with overpressure. Poke the chin out. Extension with overpressure. This is very important. With extensions, primarily, if the pain is felt, then it will confirm that it is articular or it is joint involvement. One hand, I am keeping inferior to the chin. One hand is kept inferior to the chin. And the other hand, I'm going for the hood grasp. You see, you just imagine about the snake hood. That mid finger is coming to the glabella. And then you are applying the overpressure. Going overpressure. 1, 2, 3, 4. Gentle force. 1, 2, 3, 4. If the pain is felt, that confirms the involvement of the joints. Earlier on the skeleton, I just showed you the CO, C1, C1, C2, and C2, C3 joint. With extension, if it is painful, that will confirm that there is articular involvement. With flexion, if it is painful, that is going to primarily confirm that there is tightness of the suboccipital muscles. Flexion with overpressure, extension with overpressure. Next is lateral flexion with overpressure. For lateral flexion of, say, you have to stabilize the lower vertebra. You are doing for the CO, C1, you have to stabilize the lateral aspect of C1, side bend. Give overpressure. 1, 2, 3, 4. Gentle overpressures. If the pain is felt in same side, now I am doing the lateral flexion to the left side, and the pain is felt in the left. That means there is articular involvement in the left side. While doing so, in the right side pain is felt, there is periarticular tightness in the right side. See, this is the lateral flexion, same side pain, articular involvement, opposite side pain, periarticular tightness or injury. So the next is the rotation. For rotation of upper cervical spine, and rotate. So basically, we are using the Fritz law. There is one biomechanical law called as Fritz law. We are using that. So my request to all the participants is that if you have got any queries, please write down in a piece of paper, other than interrupting or writing something during the session, because you can understand that we are not in a didactic session where we are seeing each other in the front. So if you write something that pops out and it creates some kind of flutter and breaks the third process, what I'm trying to communicate, and it does no good for you and for me. So what I suggest is that please, whatever question comes to your mind, I will answer all your questions at the end of the session. You write down in a piece of paper, and then when we ask at the end of session, I will request Dr. Neha, Dr. Mehul, or Prakasha. That time you write down the questions in the chat box, and they will read out the question, and I'm going to answer and solve all your queries. So please don't get hurry. Just write down your question, and it all will be answered at the end of the session. So I just mentioned to you flexion with overpressure, extension with overpressure, lateral flexion with overpressure. The next is rotation. Take the neck for flexion for about 20 degrees, rotate. Go for the rotation, and then in the hand there is a gap. You place the ears in this gap and give overpressure. Go to the barrier and give overpressure. 1, 2, 3, 4. And if the pain is felt in same side of rotation, then there is periarticular tightness or injury. Pain is felt in opposite side, articular involvement. So this is how we do the examination for the upper cervical spine. And next, coming to the lower cervical spine. So the lower cervical spine examination, I'll tell you the active movements with overpressures, and then I'll be showing you the landmark for the joint mobilization techniques. So coming to the lower cervical spine, active movements with overpressures. Bend the neck forward. Flexion with overpressure. You have to stabilize the thoracic area. And then from the occiput, apply the overpressure. Go to the barrier. 1, 2, 3, 4. If the pain is felt, it is due to periarticular tightness or injury. Now, what can be the possibility of periarticular tightness? There can be tightness of the traps that can produce the pain, or levator scapula that also can produce the pain, or there can be capsular tightness that also can produce the localized pain. Flexion with overpressure. The next is extension with overpressure. Take the neck for extension, right? Again, going for the hood grasp, mid finger is coming to the glabella, overpressure. 1, 2, 3, 4. Pain is felt, confirms articular involvement. Flexion, extension. The next is lateral flexion. We are discussing about the lower cervical spine. Lower cervical spine is from C3 to C7. Upper cervical spine we have taken from CO to C3. So suppose we are doing the lateral flexion for C5, C6, and we have to stabilize. And how to palpate? You know, the vertebra prominence. Vertebra prominence is C7. And along with that, we follow the dynamic method of assessment. What is the dynamic method of assessment? We ask the person, we take the neck for extension, and we keep palpating from upper thoracic region upwards. The first vertebra which moves anterior, that is C6. Now here, this one is going anterior, so this is C6. Above that is C5. So if you are doing the lateral flexion, for the C5, C6 area to the left side, I'm stabilizing the lateral aspect of C6. Any segment we are doing the lateral flexion over pressure, the lower vertebra of the concerned segment has to be stabilized. If we are doing for C5, C6, C6 has to be stabilized. We are doing for C4, C5, C5 has to be stabilized. So C5, C6 I was demonstrating. My hypothenar contact, lateral aspect of C6, side bend, over pressure, 1, 2, 3, 4. Now, if the pain is felt in the same side, articular involvement. Pain is felt in opposite side, periarticular tightness or injury. And another very, very important thing, like a litmus test to identify the facetal involvement or soft tissues, whether it is, involvement of the passive component or the articular component, or it is involvement of the active component or muscular component. How to isolate? We have the combined movement test. So what is the combined movement test? Now, you just see from here, we have the compression pattern and the stretching pattern. The components for the compression pattern, say for the right side, cervical spine, lower cervical spine, extension, side flexion to same side, and rotation to same side. I'm doing for the right side. See, extension, side flexion to right, and rotation to right. With each component, and maybe this is very, very important. So now, at least while you are listening, you can comfortably do this. So let us do the compression pattern for the right side, lower cervical spine. So let us all of us do. I am doing. You also can do that. Extension we are doing for the right side. Extension, side flexion to right, and rotation to right. This is the compression pattern. What is the stretching pattern? Flexion. We are doing stretching pattern, say for example, right side. And better I will tell you that if you are attending and listening, now you can do the movement yourself to experience what and understand what exactly we are trying to do with this combined movement. This is very, very important. So stretching pattern for right side, flexion, side flexion to left, and rotation to left. Now, what happens with compression pattern? Extension, side flexion to same side, rotation to same side. Compression pattern, the pain is felt. That confirms articular involvement. And the stretching pattern, pain is felt. So as I'm standing in the right side, I'll be doing a stretching pattern for left side. Because if I change the position, then again, visibility, changing the angle of the camera will be difficult. So for the left side, say stretching pattern, flexion, side flexion to right, and rotation to right. With each component, if the pain increases, that confirms periarticular tightness or injury. Basically, for the muscular involvements, we can identify with the stretching pattern. And compression pattern is for the articular involvements. So next, I'll tell you about the landmarks. Before I go for the, these are the active movements with overpressures. Then coming to the landmarks and the various slides. And at the end, I'll show you what are the cervical manipulation techniques. So how to palpate for this upper cervical spine? Lower cervical, I already told you. You palpate from external occipital protuberance when you palpate down. The first bony prominence is C2. This is the C2, the first bony prominence. Between occiput and C2, there will be a gap. Between the occiput and C2, you can palpate your one neck from external occipital protuberance, palpating down. This is the first C2. This gap corresponds to posterior arch of atlas. And from the posterior arch of atlas, if you palpate about 1 inch lateral, approximately 1 inch lateral and about 4 millimeter upwards, you can palpate for the occipitoatlantal joint, which is convex and concave. And posterior arch of atlas, about 1 inch lateral and 2 millimeter down, you can palpate for C1, C2 biconvex joints. And from the C2, palpate about 1 inch lateral and 2 millimeter down, you can palpate for the articular pillar. That corresponds to the facet joint. The C2 and down, these joints are called as the facet joints. Or also they are called as Z joint, zygapophyseal joint, apophyseal joint. They are all the same. And these are the facet joints. And from the spinous process, as I said, from C2, 1 inch lateral and 2 millimeter down, you can palpate for the facet joint. So I'll tell you what are the various mobilization techniques we are going to discuss. So we have the central PA glide. Get the pillow. Okay. So just here, focus on there, right. So external occipital protuberance, when we are palpating down, the first bony prominence is the C2, posterior arch of atlas, about 1 inch lateral and 4 millimeter up. This is the occipitoatlantal joint, 1 inch lateral, 2 millimeter down, C1, C2 biconvex joint. From C2, 1 inch lateral and about 2 millimeter down, we can palpate for the facet joint. C3 also same relationship, because we are, and another important thing is that we have to do the mobilization in the loose back position. And loose back position is the neutral position. You know, we all know that in cervical spine, we have the cervical lordosis. So we have to obliterate the cervical lordosis. That means we have to keep the cervical spine in straight position. So how to achieve that? We have to, while we are positioning the person in the prone lying, we have to ask the person to interlock the fingers and put the forehead on the palm. So going by that, we have to ensure that it is straight, and then we start the palpation and mobilization. What are the various mobilization techniques? I will show on the skeleton and then I will do on model. See, we have the central PA glide, the midline, central PA glide. And then we have the lateral PA glide to the lateral joints. Lateral PA glides. Lateral joints, I already told you that how to palpate for CO, C1, how to palpate for C1, C2, how to palpate for C2, C3. So lateral PA glide. And then we have the transverse glide. This is the transverse glide. Lateral to the spinous process, we have to place the top pulp of the thumb and give the transverse glides. This is the transverse glides. So central PA, lateral PA glide over the facet joints, and then the transverse glides. So these are the various glides I'll show you. I showed on the skeleton because this is definitely for more better seeing directly. You can see the joints. Obviously on the model we have to go by landmark and go for the mobilization. Again I'll tell you, midline we are giving the central PA glide, then the lateral PA glide, then we have the transverse glides. And the transverse glides are very, very useful techniques. You know, in fact, all the glides are very, very useful. Okay, now just come to prone lying position. You remove the skeleton. Yes. The subject comes to prone lying position. Just fingers are interlocked. You can see here, and okay, right. Fine. So now go down. We have to ensure that the cervical spine is straight, the lordosis is obliterated. And if there is more lordosis, you have to adjust from here. Ask the person to do the chin tuck from there and maintain this position. External occipital protuberance, palpate down. First bony prominence is C2. Here is the posterior arch of atlas. So support with these 4 fingers like this and give the central PA glide. So just okay. This is the central PA glide. See, you have to give the various grades of Maitland. Grade 1, small amplitude movement. Grade 2, large amplitude movement. Grade 3, large amplitude movement. Grade 4, small amplitude movement, and no grade 5 we are giving. Normally there is no pain. If the pain is felt, that means the joint is affected. Central PA glide. See, proceed to grade 1, 2, 3, 4. Normally there is no pain. If the pain is there, that means that joint is affected. Central PA glide. Then lateral PA glide. Posterior arch of atlas, 1 inch lateral and about 4 millimeter upwards. Place the tip of the thumbs. See here, we have to support the lateral muscles. Because if there is unusual tightness of the muscles, then that may create restriction of joint movement. So we have to support the muscles. Keep the glides. 1, 2, 3, 4. Normally no pain. If the pain is felt, then the joint is affected. The joint is affected. This is the final part of examination. These are called as PAIVMs, passive accessory intervertebral movements, and the beginning part of the treatment. So if this COC1 joint is affected, we have detected, then we go for the mobilization. We have to start with about, if there is involvement, start with grade 2, and then we have to progress for grade 3 movements. And grade 2 movements, we have to give about 10 to 15 glides for the treatment purpose. Okay, that's about the lateral PA glide. Central PA in the midline, same thing applies to the lower cervical also. I told you how to palpate for the C7, vertebra prominence, C6, the vertebra which translates anterior during the extension, and above that C5, C4 like that, and you can give. This is the central PA glide, the lateral PA to the facet, and the transverse glide. The spinous process is there, just lateral to the spinous process. Place the palm of the thumb, reinforce it, and give the glide in the transverse plane. Remember one very important thing, especially for cervicothoracic joint involvements, the transverse glides are very, very useful. Because every vertebra, why these glides are important? You know, every vertebra has got 3 axes, 3 planes, 6 degrees of freedom, and total 12 movements. So what happens when we find the stiffness in cervicothoracic area? That means this is the y-axis. Y-axis, you see the vertebral body is there. This is the y-axis. Through the transverse process is the x-axis, and through the spinous process, that is the z-axis. So around the y-axis, this is the y-axis, perpendicular. Around the y-axis, we have the rotatory movements. Now, when there is stiffness, we have to give the transverse glides, and it is one preeminent technique to deal with the stiffness in the cervicothoracic area. So these are the various mobilization techniques. Then I'll tell you, I'll show you some slides before we move further. I was talking about, just to make a small revision of certain things, then we will move again for the practical demonstration. As I said, for proper functioning, we require articular or the passive component has to be proper, then muscular component, then the neural component. So you see, this is the COC1 joint, the convex and concave. Just I showed you on the skeleton also and on the model also, the mobilizations. And again, I'm just telling you the C1, C1 joint, and this is the C1, C2 biconvex joint. You can see here. This is something very important. This is the vertebral artery. You can see here. So another important slide from the inside the facets. You can see inside the facet, we have the synovial folds. And sometimes due to inappropriate positionings, due to, suddenly you would have experienced, you are traveling, say, overnight in the bus, then you suddenly get up and then you are not able to turn your neck, or sometimes you slept at night. And every day we sleep, but sometimes, why I'm telling you that sometimes significant sleeping means you get up and you find that there is a lot of pain in the neck and you are not able to turn your head. What can be the possible cause is that the synovial fold has come out of the joint. This is the facet joint, and this is the joint capsule. And the joint capsules are very highly sensitive. And once it has come out, it is going to irritate the joint capsule. So with mobilization, as I said that we are mobilizing the facet joint, it has come out. With mobilization, slow movements, we can put back the synovial folds to its original position. Again, another slide. This is the synovial line fat pad extending inside the facet. They are called as the meniscoids. Sometimes there is a meniscoid displacement, and this is the one research. Meniscoids, also called as synovial fold, are intra-articular fat pads covered with the synovial membrane by Friedrich in 2007. Cervical facets oriented about 45 degrees from the transverse plane. About the cervical facet joints, already I just told how to palpate, and they are very sensitive. And this is the C1, C2 region. This is the transverse ligament. And you know, today we hear that you know, the actor Sushant Singh Rajput has committed suicide. That's what we got to know from the news, and it's very unfortunate. But you see, why I'm telling this is that when somebody is hanging during the hanging, and this is the transverse ligament which goes for the tear, and after that the odontoid process pierces the spinal cord and the medulla oblongata, and that's how the person dies. And so this is about the landmark for the involvements. You have got any facet involvements surrounding that, you would have the referred pain. This is, I was talking about, somebody has got a prominent line above and below, there is hypermobility or stiffness. And in these cases, the transverse glide techniques are very, very useful. Because here the swelling is appearing, primarily there is restriction of movement around the y-axis. It's more closer. Observation, I already told you that we have to observe from the anterior view, lateral view, posterior view. If there is excessive anterior translation, what we are supposed to do? Which technique are going to be useful? That I am going to show. That again, it has translated posterior to anterior. So most effective technique to treat is anterior to posterior glide, anterior to posterior translation. The examination we are doing for the, the lateral flexion. And before that, I just left one component, which I'm just showing here. This is called as PPI veins. This is also very important for assessment, where we are putting the mid finger in the interspinal space. Index and ring finger is placed on the facet. This is called as passive physiological intervertebral. With flexion, the joints are supposed to open up. I'll just again, one second, I'll just show. Subject in side lying position. Mid finger in interspinal space, index, ring finger on the facet. I'm taking it for flexion, extension. With flexion, I can feel the joints are opening up. With extension, the joints are approximating. And very important point is that normally, when we are doing the movement, as I showed that subject in side lying, and we are doing for flexion, extension, lateral flexion, and rotation. Normally, we are supposed to feel the movement. If you are not able to feel the movement, that means the joint is affected. Very, very important. Normally, you are able to feel the movement, the joint is absolutely fine. You are not able to feel, that means it is there is involvement. Why? What is the logic behind that? Now, if the joint is incriminated or affected, the surrounding the joint, the soft tissues are also going to get adhered. And when the soft tissues are going to get adhered, that is going to create one extra barrier for us to palpate for the joint arthrokinematic movement. So you are able to feel, joint is fine. You are not able to feel, the joint is affected. That is the PPI veins. And this already I showed you, the lateral PA glides. You can see here. The reliability is quite good for detecting tenderness over the zygofacial joint as per the this publication. And especially before we go for mobilizations are fine. If we are going for any manipulative technique, then we must go for the VBI testing. It's called as vertebrobacillary insufficiency testing, VBI testing. If VBI is present, vertebrobacillary insufficiency is present, we will have dizziness, diplopia, dysarthria, dysphagia, drop attacks. These are the 5 Ds of command. So one specific, there are 12 tests, but if we are supposed to do one test, that is, we have to do extension and rotation. We have to do for both the sides. That creates maximum occlusion of the hemodynamics through the vertebral artery. And minimum duration for the VBI testing is 10 seconds and maximum is 40 seconds. And this is the vertebral artery. You can see here. It's a tributary or branch of subclavian artery. And this is at this point, this has got 4 parts. This is the part 1, this is part 2, this is part 3 and part 4. The part 3 gets commonly affected. This is the part 3 which gets commonly affected. And clinically, I told you. Now suppose you want to go for diagnosis. So then what is the diagnostic method? Then you can go for transcranial Doppler. You say I have done one research study using the transcranial Doppler, me and Dr. Anandan. You can see that we are using the transcranial Doppler, and using the transcranial Doppler we can identify the systolic velocity, diastolic velocity, mean systolic velocity. We can identify the amplitude. And now if there is any occlusion, this graphs you saw, then the graph are going to spike up. The amplitude are going to increase. If there is an occlusion, now I'll give a very simple example. Just imagine you have done some plantation in your house or flat. You have done some plantation, or you just imagine that in your village you have done some plantation where watering facility is there. So you are taking a pipe and you are giving the water to the plant. And then what happens? The pipe is suppose remaining short. So the plant is little far and your pipe is not reaching. So what you are going to do? You are going to restrict the exit point of the water. So when you restrict, the velocity will shoot up. The velocity shoots up, the amplitude will increase. The same thing happens in transcranial Doppler. If there is an occlusion, the velocity will increase. So when the velocity increases, the amplitude increases. That gives a confirmation that. So that is how, suppose, directly to what extent there is compromise, we are using the transcranial Doppler. We did a research study to see the various movements, how it is going to create occlusion to the vertebral artery. So once again, I will show you that, the transcranial Doppler. And this one is already, I have kept this particular video in YouTube, and whenever the time permits, you can just see this if you are interested. You see this is the transcranial Doppler, and this will measure in the side all the components, systolic velocity, diastolic velocity. If the velocity shoots up, that means there is compromise. Right, that is the transcranial Doppler. Useful techniques of mobilization for the treatment. You see, as I said, that head is translated, anterior, suboccipital is tight. This is very, very useful and very safe technique. Cervical epiglide. Occiput is supported. Then anterior to the mental tuberosity, you give anterior to posterior translations, and at the end you can give a thrust. Cervical epiglide. And that is going to release the suboccipital muscles also. These are the suboccipital muscles I was talking about. Obliquus capitis superior, obliquus capitis inferior, rectus capitis posterior major, and rectus capitis posterior minor. Minor is here, rectus capitis posterior minor. You can go for the MET and MFR of the suboccipital muscles. That I will show on the model where supporting the C2, and from the occiput, I am exerting a force posterior and superior. And this is the cranial base release technique. This is also very, very useful for cervicogenic headaches and dealing with the upper cervical spine of the cervical spine involvement. I am placing below the occiput and slowly applying the force posterior and superior, so that the opening up is there at CO-C1 and C1-C2 joint. This is a skeletal model where I'm showing, and this I'll demonstrate on the subject so that you, and then we can go for the facet manipulations. So we have identified, say, right side C3, C4 is affected, and then we are going to manipulate it. You see the head is rotated to opposite side. Side flexion is done to same side, extension, and the thrust is applied towards the opposite side eyeball. But this is very skillful techniques. All these manual therapy techniques are very skillful. So it is advised that you go for a proper training and then understand it, because the adjustments are in 2 to 3 millimeters, and if your understanding skill is not proper, then it can be problematic. You see here in sitting position manipulation, rotation to opposite side, side flexion and extension, and that's how we are doing the manipulation. So I'll show you those important techniques. Right, lie down. Okay. come up, right? So one thing is that come a little bit more up. The very useful technique is the cervical AP glide. The first waist space is kept anterior to the mental tuberosity, other hand at the occiput, and then you can give the glide, see AP glides. You have to go to the barrier and give overpressures. Mobilization, and at the end you can give a thrust. Very, very useful and very safe technique, this one. And then you want to suppose manipulate, then you go for the VBI testing, very, very important. If VBI is there, then VBI is present, then no rotation manipulation has to be done. VBI testing, extension rotation, minimum duration 10 seconds and maximum 40 seconds. And we have to observe the eyeball. What are the presentations? Dizziness, diplopia, dysarthria, dysphagia, drop attacks. These are the presentations. Any problem? No. Okay, we'll check for the other side. Minimum duration 10 seconds and maximum 40 seconds. Anything? No. Okay. Then generalized manipulation, that AP glide I showed you. Another very safe glide, generalized one, is the lateral glide. The first waist space is kept above the pinna of the ears, apply mild traction and give the glides. You see, give the glides lateral. Go to the barrier and you can give a thrust. And before any thrust technique, you must check for the VBA. Right. This is very, very useful and very safe technique. And thrust technique, say generalized thrust, rotation manipulation, VBI you tested, then say rotation, go to the barrier and give a quick thrust. Specific manipulation, say you have got involvement of the left side C3, C4 facet. So I'm palpating for C3, 1 inch lateral, 2 millimeter down, primary leverage of rotation to opposite side, secondary leverage of side flexion, extension, going to the barrier and giving a thrust. I have to see that whether I have to give a down slope or I have to give up slope, depending on the joint restriction. So if it is upslope manipulation, you have to give the thrust towards the opposite side eyeball. And if it is downslope, you find there is restriction towards downslope, you have to give the thrust towards the opposite shoulder. Okay, get up. So these are the important techniques of cervical spine. And I'll tell you one more technique for the cranial base release that I just forgot to mention. Here, lie down, come to supine lie. Okay, go down, right? So you can go for this pulp of the forefingers at the occiput, relax. And then you apply the force, posterior and superior, so that this is very, very useful to open up the COC1, C1, C2, and also release the suboccipitals. You can go also for the suboccipital release using the MFR or MET technique. You place the lateral aspect of the index superior to the C2, hand is kept at the occiput, and my shoulder is kept anterior to the forehead, and I just pull the occiput posterior superior. That is how I can give the indirect MFR for that, for the suboccipitals. And as far as the MET is concerned, I have to ask the person to poke the chin out. Okay, I'm giving the resistance. Just poke the chin out. No. Say slide it like this. Okay, right. Okay, so that will be isometric contraction, and we have to hold it for 6 to 10 seconds and repeat it for 6 to 10 times. So I think I'm done with because usually for cervical spine, when I'm taking the workshops, I take usually for 2 days, so it is not possible to discuss. So I tried my best to give a proper understanding of the cervical spine. And in the recent times, we are going through the tensegrity concept. And this is the layering palpation you can do for identifying the dysfunction. And this is my palpation grades. And for identifying the facial dysfunction, usually we have the layer 1 skin, layer 2 subcutaneous tissue, layer 3 superficial muscle, layer 4 is the deep muscle, because there was no grading for identifying the facial dysfunction. And this was published in my book in the year 2010, and so many other articles also we have published. According to my dysfunction, grade 1 is adherence of layer 1, 2, 3, and 4. Grade 2, adherence of layer 2, 3, and 4. Grade 3, adherence of layer 3 and 4. And grade 4, toughness in deep fascia. And grade 5 is normal. So one more last demonstration I'll be showing about that. It's published in this book. And you can go for the, as I said you, that the techniques and related to the disc. So what you are supposed to do now? Suppose you have got the disc prolapse at say C5, C6 region. So already I demonstrated the central PA glide. You put it in slight extension, leg in extension, and give posterior to anterior glide. So that is going to put the disc back into original. That's what is our attempt, to put it back into its original position. And coming to I'll show you some important. As I said, that last we'll be seeing that some important techniques for the cervical spine, and this is from my book, The Clinical Symposia in Manual Therapy. I think we just with a better view I can present it. This is from the Clinical Symposia in Manual Therapy. This is available in Flipkart, Amazon. So I'll show you some support. I'm taking the help of my staffs, Dr. Basu and Dr. Ani. So you can see the cervicogenic headaches. That is the first chapter, the difference of migraine and cervicogenic headache. As I said you that the cervicogenic headache is unilateral and migraine it can be at any part. Migraine is like a tsunami, that you must remember. There is no specific cause. For cervicogenic headache, we have clear-cut, well-demarcated involvement of the joint or of the trigger point in the muscles. Predisposing factors, sleeping awkward position, a long period of work, poked chin posture, regular clenching of teeth. And these are the examination procedures I have already discussed priorly. And what are the important techniques? You can see the cranial base release technique. Already I showed you. Cervical AP glide. I told you already about this. Lateral PA glide. Transverse glide, you can see here. Already I discussed. So all important techniques. Then high velocity thrust. Also I discussed. Then suboccipitals. Muscle energy technique also I discussed. So if you really apply these techniques, then you are going to get really excellent, wonderful results. And I was talking about the upper cross syndrome. I was talking about the upper cross syndrome, and major part of the management also I have already discussed. So as I said that this is not the end of the entire cervical spine of what we can do, but in short and in condensed manner, I have tried to share the concepts. How last part, how manual therapy helps is that change in the pain threshold when we mobilize and manipulate. There is increase in the serum beta-endorphin level following manipulation. First thing is that we are putting back the structures into their original optimum structural and functional position. Then that altered arthrokinematic reflex is going to get restored by restoration of normal joint play. With the manipulations, the normal joint play are going to come back. And then the central pain mechanisms. So the multimodal approach of treatment is the best one. Mobilization, manipulation, and exercises. Right. So you can visit our website www.mtfi.net, or you can just take down my email ID if you have got any queries certain times. You can visit our website and all connectivity you will get from there. So I am done, Dr. Mehul. Prakash sir, Dr. Neha, I'm done with my
Yes,
presentation.
yes.
So I hope I tried my best to give a more better communication to the participants, because everybody is interested in the practical demonstrations.
Exactly.
And right, yes.
Yes. So it was a wonderful session for all the participants, sir, because the main thing that you emphasized very nicely on the cervical spine, starting from anatomy, then functional, then physiological, okay, and then practical demonstration was there instead of PPT. So that was quite good, and we can say that even though the people believe that the practical sessions can be done in person, right, but still virtually we were in a position, actually you were in a position that you could make it a possible for all the viewers Facebook live and all the participants on Zoom. So that was commendable one, sir. The efforts that has been given by you, actually the one must appreciate that what sir has shown all the techniques, because the matter of the fact is practically to demonstrate virtually, okay, practically if one wants to demonstrate and that too virtually, it is quite difficult, okay, because PPT jo have that anyone can read and anyone can demonstrate, but the practical demonstration and that to a platform of virtual platform, it is quite difficult, but still sir took as a challenge, and then he did it before the starting of a webinar. I thought, sir, let's check the PPT, and sir said no, I want to go with live demonstration. So that inspired me a lot, that yes, one should have an interactive session, practical demonstration session, and people should be with the speaker for the entire session, so that environment should be created by speaker, and sir, that you created very nicely. So that is the and sir is having a vast experience in both clinical as well as academic. So a lot to learn from you, sir. A
Thank you
lot
very
to
much,
learn
sir.
from you. So participant, there might be few questions, or there might be few things that they would like to discuss with sir, they would like to communicate with sir. So all of you are requested to put your queries in the chat box. Dr. Neha, you will read the all queries, and you will communicate with to Mohanty sir, and then Mohanty sir will reply back. So yes, Dr. Neha.
Okay, sir. Sir, there is one question that which in which direction we have to give glide, or how much force we use for each and every glide.
Okay, it's a very nice question. How much force depends on the condition, because it is now suppose I'll make a very specific answer. Per se, the force is near to 0.2 newtons or 0.3 newtons. It may not make a real sense, although maybe I can tell that from point of Cartesian system or point of CGS or MKS system, that is fine. But what is more important is that we have to identify for the barrier, and the barrier will be shifting. Now say somebody has got a stiffness and somebody has neck is normal, so that the force, or approximately I can just tell you that we are giving about something between maybe 100 grams to 200 grams of the force, maybe. That is what I can just tell. But that is why a more a practical based training is under supervision is very important. Although we see virtually these are the techniques and all, but then it is like something like this. Sometimes we can see one arthroscopic surgery going on in the knee or in the shoulder, and then we think that just by seeing it can be done, but really not. So that is why a proper training of understanding has to be taken. But I think I have answered the question. Yes.
Correct.
Sir, there is one
Neha,
more
Neha,
question.
Neha madam, any other questions are there? Any other question?
Yes, sir. I have one question from the Facebook, sir. That if we are having nowadays a Mulligan technique also for the mobilization for the pain and
Yes.
stiffness. So, which is safest manipulation or mobilization we can use for our patient in initial basis, or we can use both the techniques for the pain relief and range of motion to gain range of motion?
Yes. Okay. So what we discussed was from biomechanical point of view, because what happens is every approach is based on biomechanics. Biomechanics is not based on the approaches. So let us be very clear about it. All the techniques are excellent. Syriax technique is there. It is nice. Mulligan technique is nice. All the existing techniques are nice. But then what we have discussed is from a biomechanical point of view. Everything was related to biomechanics. Now, suppose you find that there is a stiffness. Say, I'll give a very simple example. You find that you are having involvement of the facet. Then in that case, if you are using the Maitland approach, we are giving the local mobilizations there. Whereas Mulligan may use the NAG techniques. So whether you are using the NAG or you are using the facet, but you should know that that particular facet there is involved. So that specific diagnosis is extremely important. And all the approaches are great. You have got a disc prolapse, then that time the McKenzie approach is very nice. For facet, Mulligan approach is very nice technique. And especially the person was asking about the thoracic spine. You know, if there is a thoracic stiffness, obviously when there is cervical involvement, there is thoracic involvement also. So as I told you that in a limited time, and it is not possible to discuss all the aspects. So when you are dealing with the cervical spine, you must examine the thoracic also, and if there is thoracic involvement, then the rotation manipulations are very useful techniques. Short lever rotation manipulations for the thoracic spine. So that's a one. What are the contraindications? That I think already I told you. You have got a fracture displacement is there, infective arthritic condition is there, ankylosing spondylitis conditions are there. Those are the contraindications. Or psychological conditions. Somebody is psychological depressed, central pain processing mechanism. A lot of works are going on that. So you have got a mechanical problem, then the mechanical method mobilization is the best, because I'll just quote one statement by father of homeopathy, Samuel Hahnemann. And he's the person who coined the allopathy also, the terminology. Similia similibus curanter. Now, similia similibus curanter means similar things will cure similar things. Very important. You know, right now we are all suffering with COVID-19. What the scientific community is searching? What the entire humanity is searching? We are searching a solution from the COVID. The vaccine will be coming out. We are trying to take up the vaccine from COVID-19 itself. So that is what is one example. You have got a mechanical issue. Says the C2 is rotated around the y-axis to the right side. So we have to solve it in mechanical method only. And that is what manual therapy does. So thank you. Any other questions?
Sir, there is one question.
Yes, sir, there is one more question.
If a person is a geriatric patient having upper back pain, so because of the age progression, so how can we manage that patient?
We can go for the gentle mobilization techniques. We need not have to go for thrust techniques, but gentle mobilization techniques will be fine. But at the same time, we have to take the history if there is any history of taking corticosteroids, or if the one plain X-ray has to be taken just to see the condition of the bone. And as I said that if there is osteolysis or gross osteoporosis, or there is fracture displacement, so all those factors we have to rule out. But safe technique will be, if we are giving manual therapy, safe technique will be gentle mobilization techniques, not manipulation, thrust techniques.
Okay, so there is one more question, that if person is having positional vertigo, then can we give cervical mobilization technique for that patient?
Sir, if BPPB is due to it associated with the cervical, if there is a cervical involvement only, then only we will give a cervical mobilization. Now, if you have got the positional vertigo, then we will give the treatment for positional vertigo. But suppose there is positional vertigo also, and similarly, another thing is that according to the observation, what clinically I have observed is that sometimes when there is joint involvement, that also can give a symptom similar to that of vertigo. You have got a joint involvement giving to vertigo, that time we go for mobilization. But there is no joint involvement vertigo, then we go for the vertigo management. There is no point in giving mobilizations if it is a purely repetitive.
Yes, sir. That
Okay.
was all about patients.
Okay, okay.
Thank you very much, sir. Spending valuable time for our students, our attendees. Such a nice interactive session. Thank you very much.
Thank you. Thank you. Thank you, sir, for your invitation. And see you soon.
And, yes, sir. We hope we meet at campus as soon as possible.
Yes, yes, yes.
So
Okay.
most
Thank you,
welcome
thank
to our green campus.
Campus.
Yes, yes, yes.
Natural and green.
Natural and green. Yes, yes,
Yes.
yes, yes, yes. Okay, okay, sir. Thank you, thank you.
Okay, nice. Thank you.
So once again, sir,
Bye-bye.
thank you so much for accepting our invitation and giving your time and sharing your knowledge. So behalf of VN Patel Medical Campus, I would like to convey regards and thanks to all of you. And thanks to all the Facebook Live and Zoom Live viewers that continuously since so many days, you are supporting us, you are there with us, you are coming with the new ideas and questions. So thanks for the support also. Thank you. Bye.